topic, challenging question in the management of CML, will be presented by Professor Massimo Breccia. It's a pleasure to have you on the stage. So Professor Breccia is an associate professor at Spinazza University of Rome. He has a vast experience and expertise in the field of leukemias and myelodysplastic syndrome, and he has been an author or a co-author for more than a 500 reviewed paper, and he's been an editor-in-chief of the Annal of Hematology of Journal, as well as other journals. So the floor is yours, and we're happy to have you here.
Thank you. Thank you very much for your kind presentation. It's a pleasure to be here, and thank you to the Scientific Committee for inviting me here today. So the first presentation about challenging questions in the management of CML. These are my disclosure. So as you hear also before in the last presentation, chronic myeloid leukemia has become a disease with a very good prognosis after the availability of several tyrosine kinase inhibitors. This is an important information reported for the first time by the Swedish group in 2016. So the overall survival of chronic phase patients treated with imatinib mostly are now similar to that of general population. I believe an important information because changed completely and drastically the level of communication with our patients at baseline. So I will start from the debate about the definition of disease phase, and recently again discussed by the European Leukemia Net panel a few weeks ago, so the last edition of 2025 recommendations, because as you know, WHO in 2022 showed that CML is a biphasic disease and not a triphasic disease, so accelerated phase no longer exists. Partially agree with this definition because we're identified patients with chronic phase but with high risk indicators at diagnosis, so means high U.S. long-term survival score, plus 10 to 19% with basophilia in the peripheral blood, or some important and specific additional cytogenetic aberration, or clusters of small megakaryocytes with fibrosis. So delaying completely the definition of accelerated phase as reported indeed by the European Leukemia Net panel. So we have several tyrosine kinase inhibitors as a possible frontline treatment. So in Europe, 4, imatinib, 3 different second-generation TKIs, asciminib that was recently approved by FDA in the US, and near to the approval also in Europe by EMA, probably in the next December, and radotinib indeed in South Korea. So how to select the patient, how to select the first TKI as the best treatment. Now we have a possible patient-tailored approach. I believe that age and comorbidities remain the most important factors, but we have to consider a 360-degree of a patient, considering also all the other factors such as social and psychological consideration that may affect adherence, because adherence in CML as being reported associated with the achievement of sustained and deep molecular responses that, as you know, are key requirements for a possible discontinuation over time. So the recommended test, again, a challenging question because most of the group use quantitative RT-PCR. Indeed, have been suggested only qualitative RT-PCR at baseline to detect the typical or atypical type of transcript, then for the possible molecular monitoring during treatment. Cytogenetics indeed is still mandatory for all patients. Is not suggested NGS panel. Even in the last recommendation of European Leukemia Net has been suggested only for de novo blast phase, or strongly recommended indeed in the investigational trial. And so also mutations not to perform at baseline, but only in case of resistance. So in our informed decision-making in the management of CML, together with the patient factors, we can consider disease factors at baseline. So the risk levels, now the most used is the U.S. long-term survival score together with SOHO, and the additional cytogenetic abnormalities. Then in second line, we can also add the information of kinase domain mutations. In case of intolerance, indeed, what type of intolerance and the severity of the side effects, and also we have to consider the depth and duration of response to prior therapy. But on the other side, in some countries also the access consideration, so insurance coverage and potential for use of generic options now. I believe that when we decided as a possible frontline endpoint that the endpoint is the TFR, so the treatment-free remission, in particular in younger patients, that second-generation TKI should be used as compared to imatinib's similar overall survival, but you know that with second-generation TKIs we have very faster responses and deep molecular response rate in the end, so more patients are candidate to possible discontinuation. Comorbidities, I believe, that guide the selection of TKI has been well demonstrated. The use of Charlson Comorbidity Index are prognostically accepted, universally scored, I believe, because in the German study 4 have been associated with a strong negative relationship with survival, but not with remission rate and with disease progression. So we have to consider comorbidities for the possible off-target effects in the long term, suggested again by the last additional recommendations, especially for dasatinib and nilotinib after 4 to 50 years of treatment. No strong contraindications have been reported for bosutinib, but I believe that we have to look at the long-term possible renal failure and liver impairment with this drug, and no contraindication specifically or no life-threatening complication have surfaced indeed with imatinib. But what does it mean to look at the comorbidities? That if we have, for example, a patient with previous diabetes, congestive heart failure, or ischemic heart disease, is not a good candidate for nilotinib. Indeed, a patient with pulmonary diseases or pulmonary arterial hypertension, for example, is not a candidate to dasatinib as a possible frontline treatment. So even in CML, genomic data have been now reported, even if not recommended the NGS panel at presentation. I believe that we can perform NGS panel indeed in case of resistance, in particular to 2 lines of therapy. These are the data reported by the Australian group before with imatinib, and then in 315 patients treated frontline with second-generation TKIs and asciminib. So the cancer gene variance frequency reported is 18%, mostly as a ASXL1 variance. And ASXL1 in CML, it seems that was associated with very low rate of major molecular response and failure-free survival, even because in these patients there's the increased probability of acquisition of kinase domain mutation. So this is an example of a patient reported by Sue Bramford, a patient with increased ASXL1 burden at baseline, treated frontline with asciminib. You see that achieve a good response, but then resistance, and the resistance occurred for the advent of a second clone with a kinase domain mutation that was rescued together with ASXL1 by a second-generation TKI, in this case dasatinib. So suggesting also a possible longitudinal clonal tracking of cancer gene variants in CML. So the definition of response are the same. International scale should be used in all standardized labs. So you see that the complete molecular response has been indeed reported as log reduction MR4, MR4.5, and MR5 with ABL as a control gene. GAS has been also referred by the European Leukemia Net, but mostly used by the German group. Indeed, the difference in the last edition of the new recommendations are for the definition of 3 different categories: favorable, warning, and unfavorable, and changed the criteria at 12 months of unfavorable patients. So in the previous edition was unfavorable at patients who did not achieve a major molecular response. Now, indeed, are patients with higher than 1%. From the revision of the landmark analysis of the German study 4, that showed with imatinib patients who did not achieve a major molecular response had still a very long overall survival, more than 85%. Similar, so the NCCN guidelines, this is the last edition of 2026, now updated. You see that the similar criteria have been depicted in orange at 12 months. So between 1 and 10% is a patients considered with a possible TKI resistance, so patients in which was suggested to check drug interactions or to consider BCR-ABL kinase domain mutational analysis. And indeed, additional cytogenetic aberration in pH-positive clone, the so-called ACA, have been revised in 2020 with the definition of a high-risk group in which were included the previous major root, so the trisomy 8, the duplication of chromosome Philadelphia and the isochromosome 17q, but also now with other specific cytogenetic aberrations that are common in all myeloid disorders, such as, for example, the aberration of chromosome 7 and 3 or the complex karyotype, have been identified also at baseline as a possible high-risk profile, and patients who probably should undergo to a bone marrow transplant. Possible mutations, this is the last panel reported by European Leukemia Net, in which, as you see, was implemented by myristoydic side mutation for asciminib, so the most common is the A337V or T. All these type of mutation that occurred with the STAMP inhibitor, not only with asciminib, but also with the other two that are still ongoing, indeed can be rescued by second-generation TKIs or also with ponatinib. But we have still unmet needs in CML, so one of the major is that most of the patients unfortunately leave the treatment within the first year or 2 years of treatment due to the lack of efficacy. So the percentage has been reported by the UDOS registry or also in Italy by the IFA monitoring registry. So about 20% of the patients are lack of efficacy and should switch to a second line, or due to the side effects. So increase at the rate of toxicity in patients treated, in particular with second-generation TKI. So it means that we need different strategies, because as you see that half of patients achieve MMR within 1 year or demolecular response by 2 years. So key requirement if a patient would discontinue the therapy in the long term. But what about the perception of patients? Because in this patient journey, we have to consider also quality of life. This is a well-reported, I believe, survey, the so-called CMS Sun survey, recently published on Hematological Journal. So 300 and more patients were interviewed, 150 physicians. You see that regardless of the line of therapy, the primary endpoint for physicians is always to achieve MMR. Indeed, for patients is at first stop or slow disease progression or maintain and improve quality of life. That is the same topic also when patients switch from first to second or from second to third line. For patients is always to have a normal life expectancy or maintain or improve quality of life. They should be assessed even in CML. Indeed, for physicians is to achieve a molecular response. So adherence, I believe, is a key requirement for all the phases of the disease. In CML have been reported mostly for unintentional reason. So for example, for physicians is the prescription of complex treatment or the poor communication or relationship with patients. Indeed, for patients is mostly the younger age or psychological or emotional factors, or even in the type of treatment, so the complexity of treatment and the toxicity, so the side effects that can be occurred with different treatment. So TKI discontinuation, the last chapter. These are the optimal requirement, the minimal requirement that are still the duration of TKI therapy, reported at least more than 5 years, and the duration of demolecular response. So as you see, updated at least 2 years as a MR4 or beta. Remember that in the previous editions we have 3 years of MR4 and 2 years of MR4.5. So I believe that the most important factors and criteria to discontinue and to propose the discontinuation to patients is to have access to standardized molecular labs in international scale with a rapid turnaround of results within 7 to 10 days. And the threshold have been now universally accepted to restart the therapy when MMR is lost. So another unmet need is that we prepare probably about half of the patients that we treated as a possible candidate for TFR, but after the discontinuation, ultimately only 20% of the patients are able to achieve a successful TFR. So we use several combination of treatments, such as, for example, nilotinib plus PEG interferon, but without success, or even different strategies of combination without success. So we need and we search new possibilities, new strategies or therapeutic strategies to block the pH-positive stem cells in this type of patients. The situation in Italy, we collected 657 patients that discontinued the treatment. You see that is also in our analysis the level of molecular response at stop treatment. So increased is the TFR rate if patients stop in a sustained MR 4.5 as compared to MR 4. And we collected also the second attempt of TFR. So patients in second or later lines, in particular, a very small subset, only 86 patients, but I think very interesting because you see the curves. So if a patient discontinued because switched only for intolerance is a good candidate for TFR? Absolutely not. If is a resistant patient and switch to a second or later lines for resistance, so only about 25% of the TFR. So in the last 20 years, the treatment goals have changed. Now we use a patient-tailored approach to select the best TKI, but we have to balance, I believe, efficacy and safety, and in this setting and in this context, also quality of life evaluation should be assessed to optimize the patient journey. So unmet needs remain. You see that most of the patients fail to achieve the primary endpoint, or most of the patients that discontinued fail to achieve a successful TFR. So we need different strategies, especially in later line CML. But this is the topic of the second presentations with new drugs. Thank you very much for your kind attention.